Hi everyone, my name is Bill and I am a PGY1 internal medicine resident physician at Highland Hospital in Oakland. Today I'm presenting on the topic of recognizing a painless broken heart. For some background information, Takotsubo cardiomyopathy, also known as broken heart syndrome, is a rare condition characterized by transient systolic dysfunction of the left ventricle. It is frequently associated with an emotional or physical trigger. Even though the pathophysiology is not fully understood, it is linked to catecholamine release and sympathetic hyperactivity. Its prevalence is about 2% of all patients presenting with clinical manifestations of acute coronary syndrome. A typical demographic for someone with Takotsubo is a postmenopausal woman with symptoms of chest pain, dyspnea, and syncope. For our patient, we have a 62-year-old male with hypertension, diastolic heart failure, osteoarthritis, presented with bilateral lower extremity pain after ground level fall while being intoxicated with alcohol and marijuana. He denies any chest pain, dyspnea, autopnea, or dizziness. His stressors include unemployment and living with his girlfriend and her extended family. The cardiopulmonary exam was unremarkable. Laboratory evaluation has significant for an elevated troponin level at 11.21. BNP level was normal. Creatinine kinase level was elevated at 4,896. On the EKG, we see a few ST segment depressions in leads 2, 3, AVF, V3, V4, V5, and V6, along with prolonged QT interval of 703. Figure 2 here is an echocardiogram of his heart. It shows a newly depressed ejection fraction of 15 to 20%, along with apical hypokinesis of the anterior lateral wall and hyperkinesis of the basis of the interventricular septum in posterior wall, consistent with the Takotsubo cardiomyopathy. In Figure 3, we have the left ventriculogram of his heart. It reveals non-obstructive coronary artery disease, wall motion abnormalities, and the shape of apical ballooning during systole, which resemble the Japanese Takotsubo fishing pod for trapping octopus. The repeat echocardiogram 1 week later confirms restoration of global left ventricular systolic function with ejection fraction of 50 to 55% and resolution of wall motion abnormalities. In summary, Takotsubo cardiomyopathy is often underdiagnosed due to its similar presentation to ACS. The surge in incidence of Takotsubo has been observed during the COVID-19 pandemic, even in patients who tested negative for COVID. Although our patient does not fit the typical demographic of a postmenopausal woman with cardiopulmonary symptoms, he has risk factors of substance use and alcohol abuse. The pandemic has financial constraints that he is unable to find employment to support his family. Social distancing and staying at home in a small apartment with many family members place additional stress on his personal relationships. Overall, the physical stress of the fall, coupled with the psychological, social, and economic challenges accompanying the pandemic, likely only contributed to the precipitation of the Takotsubo in our patient. In conclusion, this case highlights the need for physicians to include Takotsubo cardiomyopathy in their differential diagnosis when assessing patients with elevated cardiac enzymes, even in the absence of cardiopulmonary symptoms. Patients with Takotsubo are at increased risk of subsequent complications, including stroke, transient ischemic attack, and death. Study shows improved survival rates with the use of ACE inhibitors or ARBs. Recovered patients should therefore be closely monitored by their primary care physician and cardiologist.